there, one of the things, oh, one of the things that I think is amazing is that the lack of education for even OBGYN providers after 2002, I know a lot of people are aware of this, but if they've been looking into things. But what happened in 2002 was there was a big study that came out. It was the biggest study on hormone replacement therapy and one of the biggest studies of any medication ever in the United States. It was called the Women's Health Initiative. And the Women's Health Initiative was really a study that they were looking at to try to quantify the cardiac benefit that we saw for women from hormone replacement therapy, and to try to really actually extend the group of people that were able to take, that were wanting and able to take hormone therapy. But what happened, unfortunately, with that study is because of the study design, instead of showing the benefits that we know exist for women up through the age of 40, their cardiac risk, the risk of heart attacks, hypertension, all those things are substantially lower than men. I think we all see that around that. And then by the age of 60, their risk is equal to that of men, and sometimes in some cases higher. And you've also got all these other metabolic changes that lead to, that are part of that syndrome, the metabolic syndrome, problems with glucose metabolism that leads to diabetes, which leads to more weight gain, and which leads to more hypertension, which leads to more heart attacks. And so eventually heart disease becomes the #1 killer of women overall, by far. And so what they were trying to do is saying, hey, everybody needs to be on hormone therapy because it's so cardioprotective to people. But what happened in the study design was that one of the things that they said in this study was it would be unethical. And I don't know if anyone's been involved in any kind of research, they have these institutional review boards. And institutional review boards are a good thing because they protect patients from having immoral or things done to them without their knowledge. So they say, okay, we know that if we deny women medication for hot flashes and night sweats would be immoral, because that would be putting them into the misery, as you just explained, and you put your 14-year-old through as well. And so they said, okay, well, we're going to exclude any women that have hot flashes, severe hot flashes and night sweats. And also it would be very difficult to blind women in terms of trying to do a placebo. If you're having a lot of hot flashes and you go on estrogen, what happens? They go away. So they're like, okay, so the average age of the women entering the study and starting on hormone therapy in that study was 62 years old. Well, they already had, the problems already were there. So estrogen, because of the way that estrogen works in the body, it helps to decrease the types of cholesterol that are the ones that like to stick to the walls, the plaques, forming plaques in the walls of the vessels. And so, but once you have those plaques already established from your perimenopausal days of your 40s through age 60, and then you start someone back on estrogen, it loosens those plaques, and then they form clots in the blood vessels of the heart, and they cause you to have a heart attack. And so when they saw these increased risk of heart attacks in women, that was all they needed to release to the press, which in a very unprecedented way. It was released before the principal investigators had completely, of all these different sites, had really been made aware, and before it went into the journals, it went to the press. And so I don't know, all of us, I'm 54, so all of us were probably in our, in our 30s, right? That when that came out. And so really from the time we even really thought anything about hormones, the only thing we've heard from the press is hormones are bad. They increase your risk of cancer. They increase your risk of stroke. They increase your risk of heart attacks. And that's really been the mantra from the time I finished residency in 2002 until very recently. So even I was a very poor menopause practitioner until I started having hot flashes and night sweats and being freaking miserable. And I am still a practicing full-time OBGYN. In fact, I was on call last night, which is why I'm a little disheveled. But so, and when I'm gonna click this, sorry, it's there we go. And so I was like, I can't afford to have one more night of sleep that I don't sleep. So that was the real tipping point. And it's sad for me to say that I did not treat women with, I don't think I was quite as bad as the Dr. Oz guy, but I definitely hear, like, I remember people coming in and I would say, and I would be like, oh gosh, because you get the symptom list where they make all the circles. I'm like, oh gosh. And it would be hot flashes, vaginal dryness, pain with intercourse, decreased libido, headaches, bloating, all those things. I'm like, oh my gosh, what do I have to offer this person? And the answer at that point was really not a lot. And so as that came more of my personal reality, I was like, okay, there's got to be more to this. So I started looking for the real data. And that's when I started seeing, especially because, yeah, I don't know how many of you know, Mary Claire Haber is actually one of my best friends, and we did residency together. And I will remember when I was out visiting her in Texas, and it was soon after she was getting started, just starting the Galveston diet and all that. And she went through it actually a couple years before I did. And she was telling me, she's like, oh my gosh, this is miserable. And of course I was like, oh, I don't even know what you're, because I personally actually had a hysterectomy at 44 for other unrelated things. And so I wasn't bleeding. I wasn't going through the misery of people like bleeding through their clothes and you know, having a period every 15 days and all that. I wasn't doing all that. So I was like, oh, you know, until my own sleep became compromised, that was the key. And I turned it around and I was like, this has got to change. So when we look at estrogen, estrogen is a strong anti-inflammatory. So my friends, one of my best friends was also that I did body pump with and all that. She was a nurse and she taught body pump on the side. And I started talking to her because we had been really big into osteoporosis, because I talked about her forever about, it was like osteoporosis prevention. And this is when I was in my early 30s. And I was like, I think that this is such an important part of osteoporosis prevention and resistance exercise and all that. And then I started coming home from body pump, and I would hurt like a mother. I would be like, everything the next day, my shoulders would hurt, my back would hurt, my hips would hurt because of that. Because when you lose that estrogen, you lose that anti-inflammatory. So estrogen works there. There's estrogen receptors everywhere in your body, and the brain fog, the word finding. In fact, I remember my mom saying the nouns go first. And when she would talk about what menopause, and I was like, oh, they do. I can't remember anyone's name, and so I started looking back. Oh my dog! 1 second. Hold on 1 second.
That's you when you call people different names.
Sean Chain. His name. Can't think of the cat's
Sorry
name.
about that. So that I started looking into what are the real studies. And when we look back at that, talking about I looked into people who were doing the other studies beyond the WHI. And we looked at every study in that 15 years, now 20 years from the WHI. Every other study contradicted what the WHI had said. It doesn't increase the risk of breast cancer, estrogen, certainly not estrogen alone. The estrogen and the progestogen, which is what the progesterone that you choose, the type matters in terms of risks and any inflammatory states. And there was a really great doctor named Avram Blooming. I don't know if anyone's heard of him. Avram was one of the leaders in saying, looking at breast cancer risk and saying what the WHI is saying makes no sense in terms of anything we see clinically. So I think everybody, if they do what they do, let's say you're a pilot and you have been a pilot for 20 years and you all of a sudden somebody comes forward with a new study that says, oh no, actually flying upside down is better. And you're like, wait a minute, that just doesn't even make sense. So Abram said he was an oncologist. He is an oncologist treating breast cancer. And he said, every study that we have says actually you have decreased risk of breast cancer with estrogen. In fact, you have increased risk of survival, even if you develop breast cancer on hormone therapy. And when we look at the progestin and in fact, even in the WHI study, the estrogen alone arm had decreased risk of breast cancer. And the estrogen and progestin arm did not show a statistically significant increase. And it really very much depends on what estrogen and progesterone you're using, because the types of estrogen and progesterone that they used in that study was the Premarin, which was the conjugated equine estrogen, and they used the medroxyprogesterone acetate, which is a progestin that is not a bioidentical progestin, and it has a much
Stop
more
you there for 1 minute.
inflammatory. Yeah.
And can you explain where that progestin comes from? Because you said it's equine.
Yeah, so the estrogen is, I mean, it's natural. It's a conjugated equine estrogen comes from pregnant mare urine. So it comes from horse urine, and there is a lot of PETA stuff that says that these horses are treated horribly, which is not true. The horses are, so it's not, if you don't want to
Synthetic versus kind of
right,
natural.
and it's as natural as it can get.
Okay.
It's from pregnant mares, so horse urine, but it is but it still is not the estradiol that you and I would use, where that is chemically or body identical to what we use. And then the the medroxyprogesterone acetate is a progestogen that's made from another type of hormone, and then it's modified to be in the chemical formula of progesterone. So it is more inflammatory than what we typically use in menopausal hormone therapy, which is a progesterone that is exactly similar to what your body makes. So these things are what we typically use would be a body identical estrogen and a body identical progesterone. So when you look at people that are like you guys and myself who are trying to stay fit, trying to keep the bone strength, we're trying to keep our cognitive function. We're trying to look at our skin, like everything, like you were saying, we lose 30% of the collagen in our skin within 5 years of menopause.
Yes.
And but we're not just losing it there, we're losing it in your bone. Yeah. And collagen is stretchy, and it's what makes our skin stretchy. It's what makes our bones more bendy so that your bones can take impact. So because when we look at trying to replace the bone, and you look at the medications that they're like, oh, well, you can take Fosamax and those kind of things, those are bisphosphonates. They make your bone architecturally more solid, but they don't make it more bendy. And so if you lose that bendiness, then even if you fall, it's not as bad as falling and having absolutely no texture to your bones. but you're not able to sustain the impact that you would with maintaining the collagen. So I feel like I'm just rattling on. Oh, sexual function. What do you want? Do y'all want to talk about that? That's actually part of one of my specialties.
Yes, please.
All right. So just in terms of menopausal sexual health, genitourinary syndrome of menopause is what we used to call vaginal atrophy. Also, another horrible term for it is senile vagina, which is another. So we don't call it that anymore. But the main thing I think that's super important and very interesting in a lot of the research that we've had come out in the last couple of years is looking at that it's not, the reason why they call it genitourinary syndrome of menopause is that it's not just the vagina and it's not about just about sexual function. The most important thing that you can do in terms of maintaining the vaginal estrogen is to protect your bladder. So I don't know how many people have taken care of older relatives, or if you've worked in a hospital setting at all, you know that older ladies get UTIs, and when they get UTIs, they get cognitive changes. A lot of times people, when you see an older relative, the first sign that they have a UTI is they act like they have dementia. I don't know if you've ever had that, but that is, and so when we look at, there was a study that came out this year that said that 25% of admissions to women over 60 in the United States to the hospital are due to bladder related and infection related problems. So if we could do estrogen in the vagina twice a week, and it's not just for the ladies that are sexually active, it's actually to help protect your life and your health, because urosepsis is one of a huge cause of mortality. But when we do talk about sexual function, because I remember I'm definitely going through different phases, and you're like, that's the last thing that I even have on my mind, because you're so busy, and then you've got all these other body changes, and you may have kids, you may have business things, everything is blowing up at the same time. And there's the hormone changes that affect your brain. And then there's also the neurotransmitters. So when we look at sexual function in women, those are the two big players, the hormones and the neurotransmitters. So the hormones, you certainly get those vaginal changes. And as my friend, my best friend was over here the other day with her husband, and you know, that's the friend that we've had babies the same time, we've done everything. And she said, and we finally, I got her, talked to her about that. And you talk about sex, right? So I was talking to her, and she's like, I don't know why my husband insists on wearing that condom that has the razor blades on it, because that's what she felt like it was feeling. She said, she's like, so I was like, what is going on? So we I put her on some vaginal estrogen and got it. And so that was our conversation the other day. It was like, please, thank you for having him helping me remove the razor blades from my husband's penis. So that was good.
And so that worked. That's amazing.
It's amazing. So when we look at those changes, within 1 year of your menopause, which menopause is just a year to the day of not having a period. Of course, there's changes for 10 years prior to that, but within 1 year to the day of not having a period, 65% of women will have genitourinary syndrome of menopause changes to the vagina, 65%. And within 5 years, 85%. And nobody talks about it. Nobody says, hey, and I remember hearing from these sort of misogynistic guys in my practice, you know, but these were the, you know, senior members of the practice. They're like, well, I just tell people use it or lose it. And they're like, what? It's, you know, so anyway, it's just, things have changed a lot. You really need to, it's not, yes, we want to be able to be sexually active, but even for women who are not sexually active, or they don't have a partner and they are just using a vibrator, or they want to maintain their sexual function for themselves, not even if they have a partner. You need to preserve the architecture and the nerves and the blood flow to the vagina and the vulva and the bladder, just so that you decrease the risk of infection, but also you've got the tissues are healthy and can even respond at all. It maintains the blood flow to the clitoris, the labia, the vagina, and the bladder by doing just, and it's not that much that you have to use. So even my patients who are like, nope, I just don't want to do, I'm too afraid of breast cancer, I'm too afraid of heart attacks, I'm too afraid of blood clots, even though that risk with transdermal low dose, menopausal dose estrogen is very, very minimal. Even my breast cancer survivor patients now are candidates for vaginal hormone therapy. So does anyone know, if you had to guess, how much estrogen is in a year's worth of vaginal estrogen? What would you guess? Like how many, if you took a oral estrogen pill, and how many of those oral estrogen pills would you think is in like a year's worth of vaginal estrogen? Anyone guess at all? It's two pills of vaginal estrogen in a whole year's worth or two pills of oral estrogen are in a year's worth of vaginal estrogen. So that's all it takes to keep you out of the hospital, keep you being able to function sexually. It's not that much to really help preserve your, not just your lifespan, but your health span. So the other part of the sexual function is neurotransmitters. Neurotransmitters are what send you, this is your biggest sex organ, right? So for women, sexual function is so different from men's sexual function. Everybody has the same loop of desire, arousal, plateau, all the stimulation. But the problem is that men's problem is not desire in general. Men's problem is arousal. They can't get erect, which is basically a plumbing problem. Our problem is we can't even get to desire. We don't even want to do it. It's like the last thing, you don't even want your foot to touch his foot because maybe they might think that you want to have sex, or you're like, so it's just like, so how do we get to the desire? And if anyone's ever done any sort of elimination diet where you say like sugar busters or one of the other things, and or keto, you totally cut something out. And at first, in the first couple of weeks, you're like, oh my God, I would kill for a Snickers, but then once you get past like 6 weeks, you're like, I don't even know why, like Oreos sound disgusting to me. I don't even want, and then that is in your desire center of your brain. And that is where that desire for sex cuts off, because you get to where you down regulate that desire. And so there are all kinds of things that you can do. One is you certainly have to make sure that you're not having pain, because pain is going to down regulate everything. And so if and it can be that superficial pain, but it also can be muscular pain and constricture. And that, does anyone here, I guess I'm not going to ask that, but pelvic physical therapy is a really amazing tool in our toolkit. And I don't know if you know of any, do you have any good pelvic physical therapists in your area?
That actually.
Oh my gosh.
Never.
I
Has
send people
anyone
to
heard of
pelvic
that?
physical.
I've never heard of that.
Has anyone?
No.
Oh
yeah,
my
I've
gosh.
heard
Where do
of
y'all
it, but
live?
Oh, Shannon.
I've heard of it, and
Everybody is across the
Have you
United
been?
States.
Is someone, I am going to guess.
I have not been yet. I keep putting it off, but I need to go.
Oh my God. You've got
But
to
it is
go.
really good. I totally believe in it. Yeah, absolutely.
Oh, absolutely. So I send people to pelvic PT, probably 3 or 4 people a day. Pelvic physical therapists are regular pelvic physical therapists with specialized training in pelvic floor. In my opinion, everyone who has a baby should have had, they deserve to be sent to one universally. But I have patients who have never had a baby, never had any of those problems, never had any other pelvic surgery or anything like that, that have serious problems with vaginal pain and pelvic pain, pelvic floor weakness. Even, you know, what I see often in athletes is actually hypertonicity, where they've got too much pelvic. Oh, sorry, 1 second. Hello, it's daughter-in-law. Hey, will you take care of it? Bye. Especially dancers and people who are on the Peloton all the time, they can get where their vaginal muscles are so tight that it's very painful to have sex. So a pelvic physical therapist can help work with that. It helps with incontinence, with low back pain, hip pain, all of those things that we see so frequently. And so there is a website, and it's called Herman. Oh my gosh, I'm forgetting now. If you put in pelvic physical therapy and Herman, and there's 2 words, but you'll find it. And that is, there's a find a therapist, and you can find a therapist near you, but your gynecologist should know a good pelvic PT person near you. And if they don't, then you can look for
You can ask Dr. Oz if they don't.
yes, ask Dr. Oz. He certainly will know. But no, a pelvic PT is a huge tool in your toolkit of trying to get, so pain, you have to get rid of the pain. If you don't like your partner, that is another thing you can, but you have, Herman Wallace, exactly. Herman Wallace. Thank you for that, Megan. As I said, the nouns do go first, but there you go. There is also ASECT. Megan can look that up for us too. ASECT is how to find a sex educator or a sex therapist that maybe you can work on for yourself or as a couple. But the other thing another place that's out there is other good resources are OMGYes, which is a website that you can find. And one of there's one OMGYes that's like for real estate, so don't go to that one. But there's another one that is for sex therapy. And then there's an app called Rosie. Is anyone familiar with that app, Rosie? Rosie is amazing, and it has so much information, and it is got sex therapists and all this, but it has a lot of just free information. And then of course there's like a paid side too. It's ROSY.
Okay.
ROSY. And so that is another really good info. There's also medications for what's called hypoactive sexual desire disorder. If you figured out that it's not pain, it's not any of those other things, it's just the neurotransmitters. So and HSDD is defined by over 6 months of decreased libido that is causing you distress. And that you want to have desire, but you don't have desire. And that's the basic definition of it. And that there are 2 medications that are, one that works on your serotonin receptors, one that on our melatonin receptors in the brain in that desire center. And one's called flibanserin and one is called bremelanotide, and their names are Vyleesi and Addyi in their brand names. But there are 2 medications that are for HSDD. And now just to give you a quick shot overview of what those are. One is an injectable, which it is a tiny, I've tried them all. So, right. So and it's like like an insulin pen where it doesn't really hurt. But you use it 45 minutes before sex. There is part of the problem is like, most people are like, I don't know, 45 minutes before I'm going to want to have sex. But some of my patients who are more scheduled and organized in their lives than
I read that was not for menopausal women somewhere.
It is not, but Addyi, yes, it is not for menopausal women, but we use things off label all the time. And they just haven't paid to do the studies in menopausal women and get it approved by the FDA. Actually, Addyi, which is an oral medicine, the downside of the Vyleesi is that in the first 2 times you use it, there is an increased risk of nausea. So I prescribe Zofran with it for the first 2 times, and that typically does fine. And
So can I ask a question? So you're
Yeah.
45 minutes to get horny? Is that what?
Mm.
All of a sudden you're just like want to have
that's like
sex?
the maximum. That's like maximum responses at 45 minutes, and then
You
it can
actually
last up
do
to 24
feel
hours.
like sexual desire after 45 minutes? Like,
Yeah,
woohoo.
I feel like
Wow.
that it was again 60. So almost any medicine that's centrally acting has about a 60% responder rate. I wasn't a super responder, but the people who are really responsive, they're really responsive. But it's none of them are really going to be making, like, people are like, oh, I've never seen anyone that gets where it's unreasonably like responsive.
Well, what if like, oh my gosh,
But
it's working so bad. It's like I have to have sex 3 times a day and I'm popping.
yeah, and
But
again,
not like that.
it only lasts about 24 hours, and you can only use
Okay.
it, I think you can use it 8 times a month is the maximum they say. The Addy is an oral medicine, and you take it once a day. And the interesting thing about Addy is it takes an average of 6 weeks to see a response. And it's much more subtle. So it basically is going, it's not like a guy, he takes the Viagra, he gets a boner, he looks like he's like, oh, I must want to have sex. And so but this is more like you start having more, you're like, I wouldn't mind having sex today. Which, when you go from, that's the last freaking thing that I would
Right.
want to do if you gave me $100, or even more. $100 doesn't go very far anymore. So, so for women, when we looked at the studies, it said it would increase. Then when they looked at the studies, they're like, oh, this medicine doesn't really work very well. But it went for people increase their satisfying sexual events by 1 to 2 per month. Well, when you go from 0 to 1 to 2, a lot of people are like, yeah, that's fine. For me to actually want to have sex is huge in my relationship at all. So it's not magical, but I do think that it can get you out of the doldrums where you get to this point in your relationship where you're like, this is just this is impacting our relationship by not really feeling the desire to want to do this. And you have to want to do it for yourself, obviously, but I think we all know that it can impact you want to get back to that.
We have 50 more years of life, right? If we have 40 to 50 more years of life, we don't want to live ho-hummy, we want to be excited because sexual energy is exciting and it puts a nice brightness to your life and your face, and you get in a good mood if you like it, so it changes everything,
and if that's
not just
something
that
that
one time.
if that's something that's one, I mean, certainly the endorphins are good for people and mood changes and all those things.
So
What
can I
questions?
ask about testosterone? Because some doctors, not many OBGYNs, but outside, they will prescribe a small dose of testosterone.
Sure. Testosterone is really interesting because the only FDA indication for testosterone in women, because we do not have nearly freaking enough studies in women for testosterone. It's absolutely ridiculous. There's no FDA approved testosterone in the United States for women, even though most of our lives we actually have more testosterone than estrogen in our bodies, which most people are like, what? Yeah, and so when we lose testosterone, we're losing a huge hormonal part of our milieu of our interactions. So testosterone is indicated for decreased libido, but it's hard to get somewhat in the United States because it's not FDA approved for women. So no insurance companies will cover it. And so, which is complete bullshit. Sorry. But anyway, it's
a lot of approved for men.
Oh, yes.
Yeah.
Yeah.
There you go.
So that's covered. So there is an FDA approved formulation that you can get for men, but a lot of gynecologists they're not trained to do it and so I'm at my two of my partners who we do a lot of menopausal and sexual medicine. We've been trying to train even the doctors in our group how to write for it and that's why a lot of people end up going and getting pellets. So there are people that love pellets, but they're not, the pellet formulations are not made to get women to the levels of testosterone that are natural for women. They over replace women. So that's why we get a lot of people losing hair and having acne and, but I don't understand why people do it, because there's so few actual real normal typical gynecologists that are prepared to talk to them about testosterone at all. But there are safe ways to do testosterone. There are topical testosterones that are oral. Testosterone is never safe. If you see people prescribing that, it can be very toxic to the liver. It can cause a lot of problems with your cholesterol metabolism and your liver metabolism. Topical testosterone it is definitely better. And you can use a compounding pharmacy for testosterone, and that's what a lot of people do. And because it's so hard to get the actual FDA approved testosterone gel. I've worked out, my partner and I have worked out with a local pharmacy to get the FDA approved stuff for our patients, because at like $18 a month. The compounding pharmacies are typically going to be more expensive, but it may be the best way for you to do it. They're also sometimes can be very inconsistent in what in the compounds that you get, and how it's distributed in the bottle, and everything can be, and you do have to check your levels of testosterone in case you can get too high. You actually don't have to test estrogen and testosterone estrogen and progesterone as frequently. The ranges of normal for estrogen and progesterone are much wider. A lot of times you can look at the symptoms, and not that I don't ever test estrogen and progesterone levels, but I test it much less frequently than I do for testosterone. You really do have to test it. Plus, it's controlled substance, which means that you can only prescribe it for up to 6 months without an office visit. Anyway, that's like the law. So, you should be testing it regularly and make sure your cholesterol is not going up and those kind of things. But it definitely can help with libido. It can definitely help with sarcopenia, which is a big thing which is muscle wasting. And again, we need to get better studies on testosterone and muscle loss in women, testosterone osteoporosis women. All those things you would think, why are these things not studied? How can it be that these things are not well studied in women? But they aren't. And we just got a $257 million infusion from the government for study in menopausal research. Did anyone see that with Halle Berry at the White House? Oh yeah, that happened like last week. Halle Berry was like celebrity lobbyist, I guess
she got $250 million to do a study for menopause?
It's $257 million for that will be distributed to different people doing research for midlife women. So yeah, so it's like that, because part of our problem is that we don't have studies. All the studies on cardiac health, on bone health, on asthma, they're not done in our patient population at all. They're all done mostly on white, like 30-year-old white men or 50 or 60-year-old white men. And we just need much more research, which is why in studies that are done in our demographic. So hopefully we'll be getting those. Yeah. Does anyone have any other specific questions about things?
Yeah. Ladies, ask your questions. I know that, this is why we're here, so don't be shy.
Or even just like an area.
Oh, good. Go ahead, Shannon.
My first question would be, I live in Texas, and I live near Austin, so big area. I have done pellets before. They did make me feel better, but I did not love the whole deal of that, the cutting and the soreness and all of that. And so my first question would be, where do I go and what do I say when I get there?
Sure.
And second question is, what type of collagen do you know is a good one?
That is those are two very, very good questions. First, I'm going to do the collagen first, so I don't forget. Okay. So there's tons of collagens out there, right? But the two things that are most important are these collagen peptides, and the different collagen peptides are just components that people put into their products that are different components, but they have studies. One is called Fortibone. That's the most important one. Fortibone is one of the only things that has been found to increase bone density in menopausal women. And Fortibone is Fortibone and is the collagen peptide you're looking for. And the other one is for the collagen in your skin is Verisol, Verisol, Verisol. And there's several. Vital Proteins has one, but you can't just get the collagen from Costco and call it a day. You have to look for these peptides. There's one called, I can't remember, like Gorgeous Bone or something like that. But if you look for those two collagen peptides, those are the things you really need to look for. And then the other, and they're so important. And then the other thing is, with finding a provider, there are.
Before we move on, because that's for skin. If you do estrogen, will that reverse the?
Oh, it definitely will. I feel like it does. I feel like it does. And you can even there are some studies on topical estrogen for your face.
I want to do that.
You can directly, I actually do telemedicine. And that's what I was going to say is if you can't find a provider, the two things, one is you can look for a North American it used to be called the North American Menopause Society, NAMS, but now it's called the Menopause Society. And you can look for their menopause society. You have to take a test to be a Menopause Society. Yep, exactly. Menopause Society provider. It was crazy. I actually hadn't taken the test. So myself and two of my friends, Mary Claire was like, hey, you got to take the test. And I was like, oh, shit. Okay. So I am signed up. I'm taking it June 28th. So yes, you can also, you can look for providers that are recommended. And if anybody follows Mary Claire, but she has, it's called the Pause Life. She has a list of providers that she knows are good providers that kind of use consistent, good data, and telemedicine. So there's two things. So telemedicine is, I actually work for a company, in addition to my regular job, I work for a company called Alloy, and I met the CEO when I was doing a menopause talk, and I was like, you're awesome. So, and Alloy, yeah, ALLOY. And then there's other companies like in Texas, a really big one out of Texas is MIDI, but these companies have providers all over. MIDI primarily works with, yeah, I think that's how it's spelled, MIDI, or it might be two Ds, but I don't know. And they have typically like a nurse practitioner, Alloy, and they provide, the way MIDI works is you work with them and they send a prescription to wherever, and then they send out the prescription, and then Alloy has their own medications. And so you don't pay for an office visit or anything. You only pay for the medications, but then you have access to the doctor, and it's all actually physicians, and they have people in 50 states. So I'm licensed in South Carolina. That's where I'm from, Charleston. I don't know if you can tell my accent, but I'm going to be additionally starting to get, we're just so underserved everywhere that, and not just for people who know what the hell they're doing in menopause, but there are 14 counties in South Carolina with no gynecologists. And you'd be surprised in your own states that might be the case. Yeah. So I was like, okay, I need to be doing some telehealth as well, because there's just so little access. So, but that's but telehealth. So, MIDI, Alloy, Evernow, yeah, I don't know that one, but yeah, there's lots of other people you just want to make sure. So I know Evernow, and Evernow is is nurse practitioners as well. MIDI, what else? Evernow. Those are the main one. And there's one, yeah, that's a good one. So I know that those people are all use pretty much the same kind of standards and the same recommendations, but But that's a really good way if you are finding it difficult to find a provider near you, would be a telemedicine
I
person.
just don't know who to trust. You know, you go one
Yeah,
place,
well,
oh, it's pellets, do pellets, you've got to do pellets. And then you go somewhere else, they're like, well, you need a little testosterone, but not so much estrogen. And I
right.
don't know who to trust.
Yeah, and again, the testosterone, a lot of times you can't get that through telemedicine because of the way that it is. I think if you go to a NAMS, if you can find a NAMS, if you go on Mary Claire's site, certainly she's out of Texas. But you can, if you go on the Pause Life, it'll have providers, I would think, as well. But then NAMS is a little hit and miss. I'm not going to tell you, I'm not going to lie, because, you know, not everybody that took the test practices the same way. So it is hard, but you can try to find, if you look at Mary Claire, certainly through Mary Claire stuff, everybody works about the same. That's why Heather Hirsch is another,
Yes, she's on YouTube and she's in Boston. Yeah.
yeah,
I
but
follow
she's
her.
all over. She does a practitioner. So she has like a whole bunch of people that are trained
Yes.
basically in her same,
Something like that,
methods.
yeah.
So they're in different places too, but they're independent practices, but
Yeah.
follow the same sort of guidelines.
Okay. So if I was taking just an oral estrogen, I was taking estradiol for a
Mhm.
while. Is that fine?
It is. I mean,
And it's-
oral estradiol is not the devil, which I think some people are like, don't ever take it. But it does have higher risk of really three things. It has a higher risk of blood clots, it has a higher risk of strokes, and it has a higher risk of decreased libido, because when the estrogen goes through your liver, it increases clotting factors, and it increases something called a protein called sex hormone binding globulin, which decreases your circulating testosterone. So if you so a transdermal estrogen, there's a patch, there's a gel, there's a spray, those are in general less risk of those things. So that's why I mostly prescribe transdermals, because I think that in general, it's lower risk for those things. And now, but it is, I'll tell you, it is hard to find things at a decent price so I've found I'm constantly, stalking the prices at different places. And I always ask my patients, how much did you have to pay for that? So, and so much it depends on your individual insurance but I have found that Mark Cuban
Covered in insurance?
Say again?
It's not covered under insurance?
It's covered very variably, so if you
wow.
have a high deductible, then you may have to be paying $300. I had a patient who said, yeah, I went to pick up my patches, and the patches were $300 for 3 months. But there's for the cash price for Cost Plus, which is Mark Cuban's online pharmacy, is $88 for 3 months. So, and their progesterone is only $16 for 3 months. And that's why I think that it kills me sometimes that with the pellets and the compounds, because you can get hormone therapy. It's not super cheap, but you could get it for your hormone therapy for about $30 a month, and not this like $85 or way more for the pellets and all that. So it is attainable even without insurance. So, but other people my other patient went and she got her patches were $15 for 3 months, and her progesterone was free. So you have to be a consumer, a wise consumer is the main
So
thing.
you want a progesterone, you want a transdermal estrogen.
Mm-hmm.
What were you saying about the vaginal health with the cream? Some type of
Okay,
cream?
so you can there's all these different kinds of vaginal estrogens. There's creams, there's a ring, there's probably the least expensive is the vaginal estrogen cream. And you only need as much as like that first joint of your finger. You can use that, but you can only, if you just use this much around the vagina and around the entrance 2 times a week, that's all it takes. And a lot of times people will start you on 14 days and then 3 times a week. and people get breast tenderness and they start having spotting. And all. You don't need that much. So that was the way I was taught to prescribe it. And now that I never do it that way. I do it just like twice a week and gradually get it to be better. There's another product that I love and it has recently become affordable. It's called Imvexy, IMVEXXY, because everything has to have like V's and X's in it now for some reason. But Imvexy is a little gel cap of estrogen that is in a very low dose. And that is, but you have to have your provider, your practitioner, or whatever. Like somebody told me the other day, I'm not supposed to use the word provider anymore. So practitioner. So I'm saying, so your doctor or nurse or whoever is giving you your hormones, you can get them to do the prescription to a company, a pharmacy, an online pharmacy called Blink RX. Blink RX. And it should be no more than $45 for 3 months. But otherwise, it's like super expensive. So it's just hard. You have to shop around, and that's part of the challenge where people go and they go to pick it up, and they're too expensive.
Company name, Shannon said, or Seminole?
The pharmacy is Blink, BLI. Can somebody write that for them?
I
Blink
wrote it,
RX.
yeah. Blink RX, yeah.
Right, thank you.
That's where they have to send the prescription.
Okay.
And then and the other one is Cost Plus. Mark Cuban Cost Plus Pharmacy, which is online pharmacy.
Cuban has an online pharmacy. Wow.
Yes, it's how he's going to heaven, because I think he's trying to make up for any evil deeds. Because
We know him from Shark Tank. I don't know anything.
Well, I don't know him to be particularly evil, but there's a woman named Dr. Rachel Rubin. I don't know if anyone knows her. She's a urologist. She's like said the America's foremost clitorologist. So she was like, look at the clitoris. We have a clitoris. Don't just go blast by it. And she said, she actually called up Mark Cuban and said, what the hell are you doing giving $7 Viagra to all of America on your online pharmacy, and you're sending them out to assault their partners with their penises when they have no hormones and they have no vaginal estrogen, and vaginal estrogen is $150 a tube. You know, that is unethical. So
Right.
she's like, you need to get some hormones that are affordable for women. And so that's what he did. He made sure that there are hormones out there that are affordable, even if you have no insurance. And so
Just had that vision in my head. It's so true. I mean, all these men have everything on board and they're ready to go. And we're
yeah.
like,
It's horrible.
You know, I mean, it's
horrible.
amazing. It's crazy.
I mean, I have a horrible story. I had a patient, I came in, I saw through the emergency room a few years ago, and she came in and she's an older lady, and she's had a new partner. Her husband had passed away after being ill for many years. And she came in and she had to get a blood transfusion because she had torn her vagina apart, having sex with this guy for the first time. And I had to go in and stitch up her vagina. And then, but after it was healed, I was like, hey, you know, I said, like, what was going on here? And she said, well, I was like, why did you not just stop? And she's like, well, I thought that, you know, this is just how it was supposed to be now. I'm like, oh my God. I mean, she's bleeding all over the place. So, but between a combination of vaginal estrogen, and I sent her to a pelvic physical therapist, she worked with vaginal dilators, and she was able to get back to where she had the tissue healed and then was able to expand. And she wanted to have sex. It had been years since she had that, and she wanted. But anyway, so that all that can be recovered. But the fact that she thought that that's the way it was supposed to be now is actually just tragic. And but so tell your friends it's not supposed to be that way.
There is a question.
Take the knives off the penis.
Lisa, do you recommend the transdermal estrogen and the vaginal, or just one or the other?
Oh no, a lot. So most of the time, if you catch it early, and you can definitely use them together. Absolutely, we do that all the time. Some people find that they need the vaginal estrogen, and some people don't. If they're using a transdermal estrogen, they may not need the vaginal estrogen, but it is not unusual for us to use both of those together very frequently, especially until the tissue gets healthier. If you've already got some changes and dryness in the vagina, then a lot of times we have to get it back to it. And then sometimes it can be maintained with just the systemic estrogen, but it is not infrequent at all that we use those together.
Does anybody have any questions? None at all? They do, they're just shy.
No, that's fine. Well, listen, this has been great talking to you guys. I will, if you haven't followed, there's some really great people. Vonda Wright. I don't know. Are you familiar with
Vonda,
Erin? Are you
VONDRA?
VONDWRIGHT? She's an orthopedic surgeon that does a lot of menopausal medicine and tons of research in menopausal, the musculoskeletal syndrome of menopause.
Mascani, is that her name? She's the one that tested the brains in menopause women, and they
Yes.
were very similar to like a demented patient. I mean,
Right. Lisa
yeah.
Mosconi is
Lisa
wrote the
Mosconi.
menopause brain. Yeah, absolutely. She's also part of the menopause. And we've got some other tons of other good ladies. But if you have anyone who has had breast cancer or breast cancer survivors, Corinne Men with 2 N's, MENN. She is a friend of mine and part of that whole group too. That is breast
brain
cancer.
doesn't work.
Yep, Corinne Men. I think she's one CRO. I think she's an E at the end, but yes, 2 N's at the end of Men. Corinne Men. She is a breast cancer survivor. She had breast cancer at age 28 when she was a gynecology resident, and had her ovaries removed and all this stuff. And she has tons of information about breast cancer survivorship or previvorship, which is you have a very high risk of breast cancer, just a family history, and how do you manage that? Who else? Lots of other really good people out there. So you'll see. Of course, Mary Claire has.
And you, where are you?
Yeah. And Mary Claire has her new book is The New Menopause, and it goes over a lot of stuff. I know one of the things she said is, if I go in to see somebody, what do I say? And she has a whole list in her book about questions to ask your doctor, or say, these are things that I want and all this stuff.
Oh,
So.
great.
Yeah. Just say, I watched an episode of Dr. Oz, and this is what he wanted me to ask.
Exactly. Dr. Oz says to do this. You can say Dr. Kate White, OBGYN. That's just what she says to do.
But you're on Instagram, correct?
I am. Yeah, I'm at Dr. Kate White, OBGYN. And I need to post more, but I'm not like a super poster. But they're all these ladies who are unbelievable in this space. They're like, you just need to make those reels, because there is so much lacking in education. But the other really great person, Kelly Casperson, is a urologist. Kelly Casperson, Casperson. She has a podcast called You Are Not Broken. She's a urologist, does sexual medicine. Yep, that's the one.
Awesome. All right. Well, this was amazing and very helpful. Thank you so much. So
you're welcome.
I really appreciate you coming on this evening. And, the reason why we're all here is so that we can just not feel alone, right? And feel safe that we can talk about these things. So we're going to continue to talk, and I'll put out all this information. And all right, ladies, have a good night, and I'll see you all.
All right. Well, y'all take care.
Check-ins.
Thank you. Thank you.
All right. Take care.
Thank you so much.
Right.
Bye.
Bye.